Oh, sorry, yeah, diastasis recti is where the muscles that come, from here to here split open during pregnancy. They just kind of tear apart, and naturally they should come back together, but a lot of times they don't. And then sometimes women get like kind of herniations out and things like that. It's just, and what I do find is that it's women who tend to be in better shape and their abs are strong. So we tell people, like, when you're pregnant, don't sit up like this, because that splits them. So like roll to your side and come up well and all that stuff.
And you can correct that with...
Well, that's the Lose Your Mummy from the book. Yeah, it's it's a lot of work with the transverse abdominal muscle, kind of squeezing the belly button in. And that is, yeah, she has a really intensive program.
And that does contribute to instability.
Oh, for sure.
Yes, yeah.
Totally, especially with bending, because you have absolutely no abdominals, and they're important for the whole thing.
How do you know if that happens?
You can feel it. You can palpate mine later if you want. It's exciting. You press on the umbilicus and you have to do a little sit-up, and you can feel it if you sink in.
Can they go right back together?
Yeah, supposedly.
Yeah, if you're local, there's a group in Vancouver called the Tummy Team,
Oh,
which
cool.
is amazing.
Very cool.
I think she's a teacher.
It's nice.
She's amazing.
It'd be nice to be able to like go to a class for that.
Yeah.
Because it's hard when you have a baby and you're like, okay, now I'm supposed to do my abdominal work. Okay, so anyway, back to treatment. So it breaks them. I tell people to actually avoid deep stretching, especially external hip rotations, stuff like that, because a lot of people will say, oh, I just have to do these stretches, and it does help for a while, but it actually kind of increases the strain. I kind of said this in sex with legs wide apart. I probably could have thought of a better way to say that, but that's the reality, right? So, anything that just kind of spreads the pelvis. And then also things like flip-flops. Flip-flops let your ankle move more, let your knee move more, and then your pelvis moves more. So like dance goes or shoes like that tend to be good for people with more instability, is what I found. And this is, again, varies body to body. And then kind of like sinking in that soft chair or couch for too long where everything's kind of, right? And then the other, so stretch psoas, which we talked earlier about. And then the other thing I give people that I love, that I found when I was pregnant with my first baby, I forgot my ball. I love those little like pink balls, or you can use a tennis ball, so I got an apple for this. But what you do is you go through your pelvis and you sit on the ball and you start down at your tailbone but come right off to the side. So in the tissue, so imagine this is your sacrotuberous and you want to get your sacrospinous and your piriformis and you can go all the way up. And what I tell people, I'm not actually going to sit on my apple, but you start way down low like this and then you just sit on it. And you sit on the floor or some harder surface because this will be too soft. And you can kind of bring your leg around, and it's the app, and then roll up to the next spot. If you can like watch a movie and sit on these points, and this will help everybody, it's the best mimic you can do to like coming in and having me put my elbow in these. You just roll up, roll up, roll up, and the longer you can sit on it, the better, because there's this thing called hysteresis in creative tissues, which is that the longer you hold something, the more it will release. So. If you're with your first baby or you don't have babies, just like watch a movie and go through the points, and 5 to 10 minutes each point would be fantastic.
And you tell them to go for the places that are tender or just
Yes.
every place?
Places that are tender, but it's pretty tender usually for most people. And if they say, I don't feel it, I say get on a tighter, like a harder surface, or also you can really just if you're not moving your leg around like this, so you really get on those spots.
You're telling them to basically go between their sit bone and the tip of their tailbone.
Exactly.
Work your way up along.
Yeah, work your way up. And I just went and bought a bunch of those pink balls and saw them in my office for what I bought them for, because I really like them. I found that's a nice size. Oh, okay. So actually we get to change gears here. I just had to add this in because I think this is like super duper awesome. When I was in chiropractic school, one of our teachers kind of flew through this thing where like, oh, there's a suboccipital that has a connective tissue bridge into the dura mater. Next slide, and like, that was even before I started doing cranial work, but I thought, oh, that's really cool. And so last year when I was doing this 8-hour cadaver lab continuing education thing, he had a Q&A at the end, and I was like, have you ever seen this connective tissue bridge? And he said, yeah, actually we have this hemisection of the skull, let me show you. And I couldn't take pictures, but it's there. And actually when I started searching online, there's a whole journal in Spine Magazine. So here's the reference for it, in case anyone wants to look it up. It's online, you can download the PDF. So what it is it's this rectus capitis posterior minor. So I'm just introducing this in that, like, I'm looking at the power areas, right, of the spine. So for me, the power areas are the pelvis, particularly the sacroiliac joints, the thoracolumbar junction, and then obviously, you know, the base of the skull and the top of the neck. So this rectus capitis posterior minor, it's right there, attaches to the first cervical and to the spine, to the skull. And this is kind of a funky picture, but here's the muscle, there's the connective tissue bridge, there's the dura mater. I have 2 more pictures to show you. This is a fresh tissue specimen. Oh gosh, it's hard for me to see here. But here's the muscle, here's the dura mater, and there's the bridge. See those little bridges?
Wow.
Yeah. So for any doubting person, any doubting person who's like, what are you doing with cranial? How can it affect the dura? It's like, well, from a purely biomechanical point of view, there's a connective tissue bridge that pulls on the dura. That the dura is the sheath around your brain, and obviously any pull on your brain isn't so good from a nervous system point of view. I like to have things so I can explain it. My brother-in-law and my sister-in-law are doctors, and he's a general surgeon, and my husband's a Stanford PhD biologist, so I'm like, I gotta have, for my own sanity, I have to be able to explain what I'm doing to them. But so here's that other picture. So again, this is the connective tissue bridge. Yeah, isn't that incredible? It's like,
And what was the link? Could you point that out again?
Yeah.
I can't see that on.
I know it's
picture.
hard. So here's the rectus capitis posterior minor coming down. Here is the number 4 is the spinal dura mater, and here's the bridge. See those 3 little arrows? That's the bridge.
Can you go back to the previous spine slide that, and because we can't read the end.
You can't read
You
the.
can't read it.
Oh dang.
Is that online or just in the?
This is all online. I was not creative in my. Oh yeah, sorry, it's so little. I can leave this slide up at the end too. And you can just search spine 2023 and with one of the.
And then what's the source?
Spine is a journal. It's a like really well respected medical journal. So the fact that it's in there too is very awesome. And who doesn't have suboccipital muscle issues, right? And most people will come to you and say, I have a tension headache. Well, from the biomechanical, manual therapy point of view, you can ask any MD and they'll say, tension headaches are due to suboccipital tightening, and the referral pattern is it comes around and it eventually gets to behind the eye. It's one of the headache classifications that's well known in the medical world. And so then you go, oh goody. So you know about that? Well, there's this connective tissue bridge into the dura. Did you know about that? Here's the reference. Are people done with that? So and then I have one more picture of that, just because I think it's so awesome. So this is a dry specimen. Here's the muscles. Look at how meaty that bridge is. You think that person had some suboccipital tension? Here's the dura mater.
Wow.
Yeah. So super awesome.
Can you get these pictures anywhere?
Yep, they're online. My whole presentation basically, except my family photo, is totally, and it's in my thank yous, don't worry. So the hands-on, we're going to do that next, and we're going to go through these things, but before we do that, I wanted to just say this, because we might get distracted. Thanks to my dad, Dale Jacobson. He's got a really great website, jacobsonchiropractic.net. He's been doing this, 35 years. And he also wrote a book for patients, which is really awesome because a lot of people kind of dream of this but don't do it. Half of it is yoga, stretching that we give for rehab, and then half is nutritional essays, everything from gut flora to composting to milk and raw milk and, cholesterol, a lot on why cholesterol is actually good for you. So that's fun, and it's also going to be available online pretty soon as a Kindle book for like 10. What I like
You're
to
okay.
do when I first have someone on the table is just to feel their pelvis and their sacrum. And if you can kind of feel, like with Carol right away, her left side just feels like it's higher. Again, like I don't like the whole bone out of place, but this is just, this is just helping us get our grounding. And sometimes, I like to change places. I say, I guess it's the same on the other side, right? Because the way we help it, oh yeah, okay, good. Can be like, maybe it's the heel of our hand on that, But yeah, so then you just come down, and this is a little too, but just both heels to the butt. Oh yeah, good. Yay. You're cooking. Once in a while we're not, right? Good. But you can see as I push down both sides that this left side isn't coming down as far. Now, does everyone want to just do that? Let's just do it. Let's just all stay together. Because I like, stick in. Yeah. And once in a while, if they're, she's actually already even. She actually. If somebody's pretty equal, you can do a few things. You can look at their leg length inequality. Remember that AS side will create a longer leg. You can also kind of, pump them a little bit. So, push them in a little bit and see. Okay. Yeah. But, and then kind of when you do that sometimes, and again, if really it's equal, it tends to be that the whole top of the sacrum is just posterior. And again, it's like, this is fun for a cookbook, but just if you're getting confused, just feel it, And I always treat both sides anyway, so it doesn't really scheme of things.
So the restricted leg is coordinated with the potentially
Posterior sacrum. And you can see on Carol, she's already swinging around a little bit. That's not look at Carol. She's cranial sacrum. Yeah. Is she tighter on her left side? Yeah. So you can see here, that this side of the sacrum is up. It's a gross, it's a gross thing, but so after I test that, and that I just make a note of, okay, she's posterior on the left side by 2 inches, so I just say PS plus 2. Then what you do is you find the tailbone. So does everyone know how to find the tailbone?
gracefully. I'd love some.
Yeah. Okay. So, and it's so you just kind of follow the sacrum down. You gotta go for it. Yeah. If people don't want, it's just. Yeah. Yeah, the coccyx. So you just kind of sink down and find that coccyx, and then you come off to one side or the other. So I like to do it with both my thumbs at the same time. So here, the coccyx is right in between, and you just sort of, the imagination is you scoop up, kind of towards the head from the tailbone. And I can go around and help people. And this is finding that sacrotuberous ligament, right? So,
Are you right off of it?
let me get it. Let me get this spine and I'll show you. And again, you can kind of imagine this to start with, and you'll just start feeling it. But so I just kind of, so this ligament goes from here to here. No, here to here, I'm sorry. This is one we're doing. So we're just kind of scooping up. Right?
Just lengthening it, you're lengthening it?
Heather, could you just turn towards the camera and just do that a little again?
So the ligament goes from here to the sacrum, to the ischial tuberosity. You're just scooping that inward.
Great.
Yeah, so the first part is we're going to release that ligament.
On the restricted leg.
Well, again, I don't know. Yeah. But
Can jaw releases with this?
probably. So what then you do, and I can kind of, well, I'll just kind of walk through it quickly for those of you who are a little not feeling it, we'll come around after. So don't forget. Is then the side I'm on, I literally just take my elbow and I push into it. Yep, and then I just hold it for a while. And as a cranial person, I like to kind of feel what the upper, the upper pelvis is doing. You can kind of start adding things to it. But
Where's the direction of force of your elbow?
it's kind of it's
Same as what you're doing
inferior,
with your thumb?
superior, exactly. So and then you kind of scoop it. Is that like the traditional people do is and scoop it, but I'm not gonna waste my time on that.
Great.
Sorry. I love my patients, but I need to.
Which side do you choose?
I do both sides, but the tighter side again should be that AI side. But again, it really doesn't.
Yeah, and then
Do you wait for a specific release?
Yeah, you'll feel it soften. So again, the old Logan Basic people who did this, would like hold it for like 10 minutes. And they would go up each segment of the spine, and you'll feel the tissues release. And then there's a big connection, and you can actually hold, the occipital angle.
yeah, that's why.
Yeah, that's a really nice, and then feel the pulse at the same time.
Are you
Yeah,
The same spot.
again, this is a lot more force than what we do with cranial work, but you can do the same sort of thing with cranial work.
Force is up towards the space.
Yeah, and even if it's just you'll just feel, you'll feel the tightness, and then you just go into the tightness. And like, Carol's kind of rotate this shoulder back and forth. And then, you switch sides. So ergonomically, it's best if you come around your table. And you do the other side. Actually, though, while I'm on the same side, I will go up and do the piriformis. The sacral spine is the piriformis, and the glutes over the sacroiliac joint. So you start with the sacrotuberous, then you move up to the sacrospinous, which is just right above, and you'll feel the fibers, eventually doing this. And we could, you'll have the pictures on the slide, so you'll see. And you just hold that. So remember, these are ligaments. They're really tough. They don't have much blood supply. They're holding that tent up. So we need to, it's helpful to really get in there with some force and really force the length.
I like this. It's like how
Yeah, it's really pretty easy. And then once you start getting better, you can start feeling the way their pelvis wants to move
So you can
around.
add in the head.
Yeah, you can add in a craniosacral fascial release
As well as the glutes and minor.
Yep. And so then you go up. So then you come up to the piriformis muscle. The piriformis is kind of just under, like if you cut the sacrum in half, just a little bit under that. If you want to get fancy, you can kind of do this sort of thing, and you'll feel it tighten. Again, it really doesn't matter. You just go to what's tender, and you'll start feeling what's tight afterwards. You can have your circulation talk you through things, but then you just hold on. And again, if you want to hold that other hip and see, oh, okay, fine, now she'll come back with me.
Do you find that as the muscle releases, that you'll shift slightly your position of your elbow in order to facilitate that?
Yeah. And like I'm trying to explain to you, this is more advanced, but like if you grab, the front of her pelvis or whatever, and just see what her sacrum, but because like in myofascial work, how things kind of start doing a little dance, or cranial work, when they start really moving, you can just kind of follow that motion and exaggerate it. And then eventually you want to come up to right over the sacroiliac joint, which is more the upper glutes and the glute medians and stuff. And those will probably be really tender over the sprained or more unstable joint. But again, you say, okay, let me get you to like this 7 out of 10 pain, but no more, and you just hold there. And if you had a little higher table, you can do this more ergonomically, but it's pretty simple, especially. And the big thing is don't move around your elbow when you're already in the tissue. That hurts people, and it's just insulting to the tissue. So find your spot that you want to push on and then just hold it. Otherwise you're gonna, like, we're increasing the inflammation here anyway because we're forcing those tight fibers to break apart. But getting in there and then moving around will just, not good. So,
Yes.
I'm gonna leave you just, half baked. I'll do the other side after. But then, so while there's still, and then in my practice, I'll go up the spine and feel for any other tightnesses and do a little adjustment, usually in the, mid-thoracics. And then you come back through and you retest, and we should see how she feels tighter on her right. So that's okay. We lose the left. Then you just go back and retest it. And again, that's, kind of a gross test. Like, it's not, but it's a good guide mark. And once in a while, you'll get people with like a 6-inch difference of where they are. And it's just kind of a nice way to gauge, like, see if they're shifting around. Okay, so that's what you do on the back. So we'll go, you guys, after this, I'll circle it around and I'll help me. And then we'll have them flip over. Yeah.
When you're taking the front, was your elbow on the opposite side?
Yeah, again, yeah, it's kind of, that's just sort of like that's like just playing around, what do you call that? Improvise. Okay. No, I want to show how you're listening. You probably okay, so then we have them turn over supine. Yeah. So again, this is the tricky part. This next part's easier, so we'll go back to the other way. But let's have everyone just flip over real quick, and then grab both hands and bring them over, and just see if there's a shorter side. And again, this is a little bit subjective. But pretty obvious. You're right. So we're not on my midline. Exactly. Like that. Yeah. Carol just made a point that you're feeling the fascia all the way through the body. Hey, let's
Hold it down.
make it quiet for just a sec. Carol's just saying you can feel the fascia all the way through the body, which is true. And what it kind of reminds me of is, taking her classes, how she does the little subtle pushes and things like that. Like, if again you want to take this to more of a cranial sacral perspective, you could do a diagnostic tool like that and then just go, okay, I know that this side has got some really good restrictions probably all the way down. So then what you do is you just bend their knee up, stand on the side you're working on, and find their anterior superior iliac spine, which is this little bone right here. So remember that the piriform, or the psoas, comes from the bottom of the thoracic and all the lumbar vertebrae. So it starts about here. A few inches above the belly button, and it will start there and will come out to the thigh bone, the top of the femur. So if we imagine the muscle fibers running like that, what I do is I just tell you that because you could actually work on it all the way up and down. On a pregnant woman, you just do the bottom part, and a lot of people will be scared to push in deep here, especially on a pregnant woman. The baby will get out of the way and the mom will love you. This was something in chiropractic school when I was pregnant with my first baby. I had to go to the clinic, and my intern, I was like, because my dad had taught me this release when I was young, and I was like, you gotta do this. And she's like, I can't do this. I was doing like 2 or 3 weeks, and I was like, you gotta do it. And it was, really felt great. And then when I went to the Webster technique training, they taught that too, which I was very impressed with. So if you just kind of move around the knee and feel, about an inch in from that superior iliac spine, and you just imagine the fibers are kind of running this way. And if you are confused too, you can have them push up into your hand, like raising your knee, because that's the action of the muscle, and you'll feel it come into your hand. Do you feel that? You might need to do a little bit more hand.
Wow.
So then what you do is with a broad contact, because anything poke, 1 finger, 2 finger is going to be too pokey. So you try to go in with 3 or 4 fingers at a time. Just go in. And they will, a lot of times, and then you can feel, is it the psoas, is it the iliacus, they're all joined there, sometimes it's more iliacus, sometimes it's more psoas. Who cares, it's tight, let's get it released. And this is so good ergonomically for your body, I mean, you literally, and this is something like, when my pelvis acts up, I just have my husband do this to me. A lot of times husbands are too, or trained husbands, a lot of times they don't feel comfortable going this deep because they think they're hurting their wives, but this is so good. And again, then if you can kind of turn on your cranial sacral with your deep palpation, you can go, oh wow, okay, with this pressure, you know, this muscle wants to your hands in play. So then I hold that for a while. A lot of times it will be pretty dang painful for the patient, and I say, that's all right, I'm just getting you ready for labor. It's a different kind of pain than we usually have. You can, if they're squeamish, you can move their knees around to distract them. If it's not super tight, you can start lengthening, and it will put more of a stretch into the muscle. And then you just do both sides. So, the next thing, and then you can remeasure the arms and all that if you want. The next thing that you look at is the round ligament. So, with the Webster cookbook, and again, this will be in your notes, the side of the posterior superior sacrum is the side of the tight psoas. This is in your notes. Because that psoas is pulling it forward, or maybe there's something else first. But we release both psoases. And then what they say is then the opposite side round ligament should be the tight one. The round ligament on the PI side. Yeah, it makes sense. So, well, you know, it didn't, honestly, I practiced for like 2 years before this made sense. Because that, the tight touch the said that's rotated back. So it's just putting more strain on the pelvis, on the uterus, it'd be doing this. So again, there's this like formula, I could have put it in the slide,